I would like to announce our next speaker who also got involved in the discussion as a co-expert is Dr. Bernd Wegener. We get the medical view here. He is head surgeon for spinal diseases and foot surgery at the University Clinic in Munich, and he is head of the Department of Spinal Diseases and a guest professor at the University in Brussels. And in Munich, at Munich University, we had a research project on back training with EMS. He's got the current findings, how reasonable it is to use EMS post-surgical, then also pre-surgery, so that we do not get to this situation. And when there are people suffering from chronic back pain, also being successful in treatment, there are some successes you can achieve, bringing quality of life. Dr. Bernd Wegener.
And it would be even better if I could see my charts now. F5. Great, it works fine. Now you know who I am, but I don't have a clue who you are and how I can actually customize the message for you. Who is in the fitness market of you? Who is a potential instructor of back pain patients? Great. Is there anyone working in the classical medical area, physiotherapist, physician? Oh, welcome, dear colleague. Well, let's get started. You just heard that I am a full-time surgeon for foot surgery and back surgery. And when somebody actually does this and talks about conservative methods, and somebody actually tells you about other methods fighting back pain, then this is a person who doesn't make any money with it. 2 years ago, when I prepared for the first symposium, I looked for data in my specific disciplinary. I went searching for specific technical terms, and I couldn't find anything essential. There were 12 studies at that point in time that I could find for whole body EMS, which is not a lot. When you then modify the keyword, probably I was looking for the wrong term, and then actually add back pain, I ended up with 0. Search engines only told me that you can train the muscles holding the back. So lots of back pain, but little good advice. Most people from most studies from the medical field deal with sarcopenia, and Professor Dr. Kemmler will talk about this. He is the specialist. Where are you, Wolfgang? Yeah, he has arrived. He's here. Sarcopenia means aging, losing muscles, muscle decay, and how I can actually train older people, senior citizens, to delay or compensate for this decay and reduce the risk of fall, because we know that the risk of falling and the resulting injuries and fractures actually limit lifetime, but also actually worsen the quality of life. And the same point is osteoporosis. And again, we want to prevent fractures here and increase bone density and creatine kinase. This is a hot topic, and this is a highly emotional topic in the fitness market. In my personal view, and this actually correlates to what Andrei Filipovic just said, this is highly overrated when you work out properly. And if you are not faced with somebody with renal insufficiency, then the CK rate or percentage is interesting, but it will not interfere with your daily routine. And once I've run a marathon, I don't want to know what the CK values look like. Such an EMS training is harmless in comparison. Let's come to the here and now and actually search the medical databases for whole body EMS, where we can find around 30 articles. So the database has more than doubled. So we have won a lot more of insights in the meantime. In this context, we also know 3 publications on whole body EMS and back pain, and I want to walk you through these studies. The first publication by Dr. Kemmler and his working group was an analysis, and they actually found a trained subject and studied this person, and they looked for patients with back pain. To this end, they generated a control group which had comparable parameters such as a comparable diet, so that at the beginning of the study there was no considerable difference between the trained subjects and the control group in terms of pain frequency and intensity. These trained subjects or sports people then trained with EMS, and at the end of the study, they actually proved a reduction in the pain intensity. The control group did not have a comparable result, and the pain frequency also decreased considerably. So the study group drew the conclusion that whole body EMS is very effective in terms of the time invested to reduce back pain. And the focus was, of course, back pain. It could be an interesting topic to study in future, and it looks as if this might work. Another study by Mrs. Weissenfels, she's actually preparing her doctorate thesis and is part of this group of Professor Dr. Kemmler. She selected 15 trained subjects that underwent EMS training and 15 students as a control group. At the beginning of the study, the trained subjects had no difference in terms of pain incidence, but the extension of the back and in curling or crunching, there was no big difference. No significant difference between the groups. Significant always means we prepare statistics to find out whether what we're doing is a coincidental result or whether it can be proven mathematically. So significant means good and not significant means an effect you can't measure. These people actually trained with EMS and with strength training, and the results were very positive for the EMS group. You have to admit that the pain intensity level was pretty low on the scale from 2 to 10. It stood at 2.7 on average. You can't expect, of course, that there is a significant change downwards, a decrease. The effect to be expected is about 0.5 or maybe 1%, which is already a big asset. The MS group fared a lot better in terms of pain. The control group, nothing. With strength parameters, the same. The MS group benefited both from the crunch and the extension forces. The control group undergoing classical training in this same period of time, under the same training conditions, did not post a significant increase in strength. Conclusion, the training is time efficient and it seems to have a significant impact on back pain. The last and third study, bear with me, this is the last one. Again, it is a summary of 4 studies. Here, a training that lasted from 14 to 52 weeks, between a quarter of a year and a whole year. And initially, the pain intensity was taken, and there was no significant difference between the trainees and the control group. And again, the MS group was able to benefit significantly. Here, the scale was different from 0 to 7. So 1 point here corresponded to 1.4 of the scale I mentioned before. So again, pain intensity was clearly reduced in the EMS group, and the pain frequency was also considerably decreased. So the group was able to conclude that EMS is a good training tool for people with back pain. Let's talk about back pain here. Who has never suffered any back pain? One, just one. Let's count now. Then this is not so bad, because the lifetime prevalence, this is the occurrence of back pain in a lifetime, is between 65 and 85%. This is due to a guideline in Germany. So the majority of people actually suffers from back pain sooner or later in one way or the other. And on average, 60% actually suffers from back pain at least once. This is the so-called annual prevalence. When we look at the costs associated, we understand how important this is. In the German healthcare system, every year, and these figures date back to 2007, 20 billion euros are spent on the direct and the indirect costs associated with back pain. And this would be a nice amount in our account, but this is money that is spent every single year on back pain. And we don't really know what helps to significantly reduce back pain, because the figures have been constant over the years. And this is why it is the reason of costs in the healthcare system per se. Then there is back pain associated to injuries from sports, falling from a cycle. Then there is inflammation related, like spondylocytis. Then we've seen more cases of tuberculosis again. So there's a handful of reasons why people actually can have a specific back pain, but there's also unspecific back pain. And this is the back pain that we don't know the reasons for. So no inflammation, no accidents, etc. And 10% of these unspecific back pains is long-term. So they're really affected by these pains. They create high costs in terms of therapy. And of these 10% of the population who actually suffer from this long-term back pain, they account for the majority of costs that we incur every year. So what is the difference between the specific and the unspecific back pain? When we look at a patient that actually suffers from back pain, we actually make a difference between those approaching you with acute back pain. They should not see you as an instructor at the studio. This person really needs an anamnesis. Then there are different ways of occurrence. This can be pain in the back, and there's one point that hurts. But it can also be pain that actually follows a nerve, the so-called radicular pain. Then there is pseudoradicular pain, that is a pain that actually resembles the pain triggered by a nerve, but don't follow the nerve. And there is people with general pain. They can't really point or locate the pain. And I've added a sketch from a patient here. Here you can see the areas marked where he feels pain, this patient. And this is, of course, the forms that are very or relatively hard to treat. And then there is different qualities of pain. Is it itching? Is it permanent? Is it burning? And this helps you to decide. Of course, these people need to be studied and looked at by a health professional first. There's certain yellow and red warning flags in the system available, and we can actually rate the pain according to these flags. And people who've suffered from back pain for a while need some imaging. Not everyone suffering from back pain, unspecific back pain, should actually undergo X-ray. You don't have to X-ray them right away, but if they have persistent pain, then these patients need proper diagnostics. Let's talk about the red and the yellow flags. Red flags are the things that point to an unspecific back pain. Let me warn you of this. If you face such a customer, then send the people to a doctor. Don't start training with them right away. It could be the result of a fracture. This is a trauma fracture-induced, underestimate old people, senior citizens don't have protective reflexes, so even a very small, trivial trauma, tripping over a carpet edge, could result in back pain and little fractures. Then there are also drug-induced risk factors, patients that are actually treated with cortisone drugs. They have a lower bone density, and this is a very little trauma, but this can actually result in a traumatic fracture, or tumor patients after oncological treatment of inflammatory diseases. Don't forget the tumors. When somebody approaches you, older age, who actually has lost weight, sweats at night, is tired very often, and feels strange forms of pain, then don't train this person. This person needs to see a healthcare professional, because the tumor needs to be treated, but there's also a risk for follow-up damages. Then people with infections, they're low on energy, they probably have a fever, high temperature, or they sweat at night. And these patients too can have a relevant disease. And when you overlook this, then you're actually in trouble in terms of liability. And everything that actually radiates from the pain to the legs or to the arms that actually causes strength or power dropouts could be related to a prolapse, a recess that actually exerts pressure on a nerve. Not all of them need operation. Some would also improve if we don't, if the patient does not undergo operation. But in times where operations actually generate a lot of revenue, surgeons love to operate. So cutting is fine. So never forget that such diseases can occur. Send them to the health professional first, and if the health professional says yes, treat them. Yellow flags. Whenever we had an X-ray correlate to pain, we started operating. This was so bad with Corspin in the 80s, when this was the new method of choice. Any change of a disc or a vertebra, this was all operated. Very often, chronic back pain is not a structurally induced problem. We can see slight changes, but they do not really correlate with our pain. It is traces that life has left. But we know that chronic pain actually results in other disorders. This is a warning signal. You suffer a trauma, the tissue is damaged, or it runs the risk of being damaged, and this pain tells us, oh, something is wrong. Avoid this problem. Try to behave differently. But if this pain becomes chronic, it becomes the problem itself. The trigger is gone, but the pain persists. And this is the so-called chronic pain diseases. Whoever has actually suffered pain for long enough becomes strange. You can no longer perform. You try to compensate for this pain. And this is the so-called yellow flags. These are the risk factors for chronic pain that are really accessible for EMS. Depression, for instance. People who say, well, this is also horrible. Then anxiety and avoidance tactics. Many people try to control this pain by lying down, by no longer moving, which is wrong. But this is being done constantly. And this is also part of some of the therapies that are actually recommended. And we know it's wrong. We know that. If you see any of these yellow flags, this is patients who are perfect, who are actually suffer from chronic pain and could be ideal for EMS therapy. Now, a number of bright minds actually have compiled a national guideline for the chronic unspecific back pain. First version was issued in 2007 and until 2013. No, it was actually revised in 2013. And it says, if somebody approaches you with a chronic unspecific pain, well, we want to tell these people, stay active, do something, move. And there is scientific evidence for this. It does work. Behavioral therapies, there's strong scientific evidence for this. Then relaxation technologies, yoga, for instance. The moderate scientific findings saying that this works. Everything that you get in terms of drugs, painkillers that a drug administers, massages, sleeping a lot. The whole spectrum of physiotherapy may work, but only for a short period of time. There is one recommendation saying electrotherapy, such as magnetic field or ultrasound therapies, don't work at all. All of the physical measures impacting from outside don't work for this. Well, in a way, we're talking about this power, muscles, electrotherapy. By electrotherapy, the guideline understands the transcutaneous nervous stimulation. Like electromyostimulation, it is linked to a low-frequency power impulse, the bad control theory. So we send an impulse, and this impulse impacts the nervous chains, and as we feel so much impulses, we can no longer absorb the pain stimulus in our brain. So overlapping the pain stimulus with the nervous stimulus, it really does work, but only for acute pain. But in back pain, it does not work because this is a chronic pain. The second modality mentioned here is the interference power. Interference power is a medium frequency power that is applied through suction cups. So you get 4 suction cups on your back. It's like a massage with a little power. Very, very pleasant. Feels nice. Like a massage, it actually results in a short-term relief, loosens up the muscles, but we also know that once the therapy is over, a few hours later, and you're back in real life, the effect is gone. But now there was a new guideline out in 2017. It was scaled down from 198 pages to 160. The short version is now only 40 pages short, so everyone can actually read this at bedtime. And I've again tried to summarize what's contained. No difference. So the recommendations for non-drug-induced therapy are exactly the same. Movement, motion, exercise, and all of the other measures introduced from the outside are said to have no effect or only a short-term effect. The core statement is people should exercise, they should move. We increase their coordination, their balance. And this is important because it results the follow-up problems such as falls and fractures. We know that the human being is not a static body. We actually sway around our cone of economy, so we balance constantly against gravity. And this coordination can be trained through physical perception. This is what sports people know. They improve as they exercise. Strength and endurance, this is of course also a result of exercise and movement. But we have a problem. Our patients with back pain don't want to do any sports. Many don't. And they have very good excuses. Some say, I don't have no time, I have to work long hours. And it is true to a certain extent. It is an excuse nevertheless. it is well studied that these excuses helps people with back pain to say, no, I can't undergo sports, I can't do any exercise, I simply don't have the time to. And then there's the other group saying, why should I move more and exercise and actually increase the pain? This is kinesiophobia. Many of these people suffering from back pain are overweight, have changes along the spine and the joints, have the artificial knee joint, an artificial hip joint, and they are in pain. They have a problem with exercising. But when you give in, you will never come to grips with your back pain. So this is why we've initiated a project trying to measure the effect of EMS on chronic unspecific back pain. It's called EMBUR. As you can read, this is an abbreviation. We actually selected patients with back pain, and as a control group, we chose a healthy group of patients. And the back pain patients were split up into a group with classical EMS training, and the other group got a multimodal therapy concept. Multimodal, this is the buzzword of the time. We know that these people not only have a problem related to physical reasons, but they also have a mental problem. Multimodal programs therefore look after both the physical movement or flexibility of the people. They do the classical physiotherapy. They also do passive physiotherapy. But they do one more thing. They also provide mental support to cope with pain and stress. This is the golden standard, and this is what we need as a yardstick. This is what is really on today to fight chronic pain. In our study, we were able to include 128 patients with back pain. 34 were recruited as a control group of healthy patients. We failed to randomize. Randomizing means that we actually select the participants arbitrarily for the therapy. This was unfortunately not possible to do, at least not in the period where we needed some trained subjects. Some people really approached us selectively. The body street studios are pretty prevalent in our region, and this is why society has learned about it. And this is why we gave up on randomizing and actually allowed people to do what they wanted to do. We then actually were able to do the multimodal therapy over 4 weeks. Our concept was done for 6 months, and before the therapy, after 12 weeks, and at the end of the therapy period, we studied and asked our patients. The core muscles, upper arms, hip, and thigh muscles were trained in both therapies. Whole body EMS, of course, eases doing this in a controlled way. Then, of course, we came up with questionnaires because we need to evaluate pain, because pain is not only a physical phenomenon, but it is also a psychological phenomenon. And this is why we have developed a number of questionnaires that we'll talk about in a minute. The North American Spine Society score is a pain score. The numeric rating scale is a measuring instrument where I can actually give a score between 1 and 10. 10 is unbearable pain. The Oswestry Disability Index is a quality of life index and back pain. It means restriction. SF36 is a questionnaire that also describes factors of well-being, and HADS is a questionnaire that also includes depressive elements, asking patients in how far they also suffer psychologically. Then we have also included some physiological parameters, the MFTS3 check. This is a balance measuring element. People stand on an unstable plate. It's mobile and moving. And through a formula, indices are calculated that allow us to comment on stability. We did this with patients sitting and standing up. Our idea was to include patients in sitting because there the core muscles are more important. That was a clever idea, by the way, but I will comment on this a little later. The Leonardo stare actually measures time and speed and acceleration. So this is an indirect way of measuring strength and showing performance. Let's talk about results now. This is 3 scales. Let's start with the NRS from 1 to 10. 0, no pains, 10, unbearable pain. You could see that the healthy trainees had no pain whatsoever, and you can see that our blue group, this is the EMS group, and the orange one is the control group, treated with the multimodal program, had roughly the same pain conditions. Here we were able to only check up on these people for 4 weeks, and you can see that hardly anything happened. In the EMS group, we can see a drastic decrease in pain, and it actually goes on over the duration of the training. Those patients are not interested in the parameters. They're only interested in pain or no pain, because patients are not sitting in my surgery saying, well, I don't want to get rid of my depression. They would see another doctor. People tell me, I want to get rid of my pain, whatever they have to do. And obviously, they get rid of their pain. Let's look at the other score to the left, the ODI score. This is the quality of life score. And the higher the value, the worse the quality of life. The more pronounced the symptoms. The healthy group with the multimodal treatment, and blue again is our EMS patient group. And we can see a clear increase in quality of life. And the same is also reflected in the other score, where it is exactly the other way around. The more, the higher the score, the better the quality of life. The healthy people actually have a clearly better score, of course. Here, the level, the original level was not the same, but we can again see a very good increase in performance parameters in the EMS training group. Whereas our comparative group, being treated with the standard protocol, did not improve whatsoever. Our physiological parameters were very much the same. The initial level was pretty much the same, comparable to healthy people. There was a slight increase in in trunk rise. This is where you actually stand on the plate and you bend the trunk forwards and then actually curl up again. So what you need is the back extensor. The chair raising test, there is a chair that is connected to the plate, and the question is how fast and forcefully you can actually get up from the chair. We saw an improvement in both tests. The EMS improvement is not huge, but as we heard before, the effects don't have to be huge to improve the personal perception. This is older people, senior citizens who are harder to train. Let's never forget this. So the effects that you can achieve at young age can no longer be achieved at an older age. And this is why we're happy with even minor improvements. The HADS score, the depression score. There is a difference between the two groups. Nevertheless, there was a slight improvement, and we were pretty happy with this improvement. The NAS is a pain score, and the pain level was also decreased. Irritating for me, but all the more striking, is that the classical pain treatment concepts could not actually come anywhere near. In summary, we were able to show that the EMS training actually showed far better, significantly better pain reduction compared to the golden standard. There was a significant improvement in the quality of life for whole body EMS trainees. And in terms of the physiological parameters, we were also able to produce better results. So what are the take-home lessons? Well, whole body EMS is most probably an efficient training and therapy tool for chronic non-specific back pain. We have a handful of studies available now that tell us. So this is still thin ice, but this will change over the next few years. There's a number of studies. The working group of Mr. Kemmler has some more ongoing projects, so there's more in the pipeline to come. So far, we don't have many proofs, but strong indications. I'm standing here and saying EMS works, power works, and the classical therapy program doesn't, but that we find in the guidelines. Do we have to rewrite the guideline? Does electrotherapy work all the same? No, we don't have to rewrite it. And there's a simple argument. Whole body EMS is not electrical therapy, classical electrotherapy. It is not a targeted pain therapy. It is training. It does not boost circulation. It focuses on muscles. And when we think of the microwave frequencies, they above all increase circulation. No, EMS is something different. We're speaking of a method that allows people to exercise, people who don't like sports, who don't want to move, who don't want to exercise, thereby helping them to control their pain a lot better. When you actually do such a study, you have to admit that we received some sponsoring from the equipment manufacturers. We were allowed to use their equipment free of charge, but apart from this, they did not actually give us any money or co-funding. We were able, at the annual Congress for medicine, for electrophysical medicine, there's a specific EMS session. If you have data, please submit the data. If you want to know about medicine and whole body EMS in general, you're cordially invited to participate. On the occasion of the session for 1.5 hours, we will actually try to provide a cross-section of medical knowledge. The question that was asked before, what about diabetic patients? That's interesting. We will cover it. What about people with heart insufficiency? What about tumor patients? There is quite a bit of data available presented by high caliber speakers that will actually answer your questions. Well, I would like to thank you for your attention, and I'm available for questions now.
So please do go ahead. Go ahead. Ask your questions. Please take a mic also, because otherwise the interpreters don't stand a chance of interpreting, even if you speak loud and speak up. Questions? Well, not all at the same time. Well, he wants to move on and watch a match. Which one? Well, the one.
The match, of course, at the Allianz Arena.
One question. Which training parameters did you work with? The classical, strength program?
Exactly. We didn't do any experimental stuff. We tried to apply the basic program for strengthening, and this is provided by the MIA Bodytech equipment, simply because we thought, well, this is what expects patients later on the market. It makes no sense to come up with a highly sophisticated routine if you can't offer it on a broad-based level later. And this is why we went for the widespread equipment with this widespread routine.
But then we do not have the direct comparison with electric therapy, because the intensity and the way of working is different.
That's an important aspect I tried to work out. We do work with power, with electricity, but we don't do what the electrotherapy does, because it mainly focuses on relaxation and boosting circulation. or focuses on the stimulation of individual muscle groups. This has been around since the 70s, but this is not our cup of tea. We have a tool that actually makes people exercise. This is not a specific pain therapy program, and this is important to remember.
Right there at the back. Well, have you also gained experience with different frequencies, 7, 80 hertz, 100 hertz, or did you only concentrate on 85 hertz training?
We worked with the 85 frequency. There is a presentation by Michael Fröhlich from Kaiserslautern, and that working group actually worked with very low frequencies. But the core statement is, without anticipating this presentation, that you can actually produce very nice training effects with low frequencies. Whether it's better or worse, I don't want to comment on this. But the lower the frequency, the more unpleasant the application. And this is why this is a double-edged sword. We have tried to apply the frequency that is widespread on the market. And what the best frequency really is at the end of the day, well, there's a lot of work that needs to be done. It's not only about the frequency, it's about the on-off time. There need to be more chapters added to these books. I think this is not so much a question for the physician or the physiotherapists, but we need support from the scientists here. We have to work together there.
Any further questions on your part? One last question I would allow when I look at my watch. So, a question from the gentleman next to me. He's not speaking German, but he asked me to pose the question. Well, where do we find links where we can obtain more information regarding the studies this presentation is based on? Is there a website, or where could you get information?
You can find the medical studies in databases that you can access. The database that I used is PubMed. PubMed.com is the name, or Medline, whatever you prefer, or sciencedirect.com, and you will find all of the studies there. On the national scale, there is a working party called Arbeitskreis EMS, and most of the people speaking here meet in this working party, discussing the next hot questions, and there's a homepage. The classical scientific data would actually be available through PubMed.
Thank you very much. Well, right, one piece of information. All the presentations delivered today are recorded by video and will be available online as of early May. When you get this QR code on your smartphone, you've got a direct link to the presentations that will be online as of early May, because many things you have to think about and say, hey, what did he actually say? What was it like? And there's another possibility of accessing the information. So another round of applause, Dr. Wegener. Give him a hand. Thank you very much.